we are doing an abdominal exploratory in a dog that has a biliary mucocele and also has what looks like obstruction of the common bile duct. On the CT scan, we did see an adrenal tumor as well, and so we don't know whether the adrenal tumor is a pheochromocytoma or an adrenocortical tumor because it's not showing signs of Cushing's disease. And so we'll just see how we go once we start manipulating it as to whether we start getting tachycardia and hypertension. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you get a ding on your phone the next time we live stream. And join our YouTube membership if you haven't already done so, because this video will probably go on to the membership only after the live stream. So again, this one has a history of a biliary mucocele. It's been treated medically for an extended period of time, and then the owner was concerned that she acutely deteriorated last night, and they did blood work which showed elevated liver enzymes but also elevated bilirubin. And so normally with a biliary mucocele you shouldn't see elevated bilirubin unless you've got an obstruction. So when we did the CT scan today, which I reviewed in a separate video, we saw that there was a dilated cystic duct as well as a dilated common bile duct. And incidentally, a left adrenal gland tumor. So grossly the liver looks pretty good, maybe a little bit rounded. Do you want to ligature off that falciform?
She's way ahead of me.
And can you guys please confirm that you can hear me on the live stream? Some tiny little delicate right angles would be great, thanks. So we've got our Balfour retractor in here. Always want to use Balfours when you're doing an X-lap. You want to make sure that you open up far enough. And I like my Balfours to have a spoon because that's going to keep the Balfour centered. So we'll start our X-lab. We can see a huge gallbladder sitting here. So just a massive gallbladder, but luckily the gallbladder doesn't look too diseased if we have to use it for a cholecystectomy. Liver doesn't look too bad, maybe a little bit rounded on the edges. Got my stomach here. Already done a CT scan, so I don't need to do as extensive a X-lap, but it's still a good idea to have a look around. So we've got our duodenum here, and we're using the mesoduodenum as our retractor, and I can see my bile ducts very dilated here. And I've got my portal vein sitting there. Vena cava is there. Got my right adrenal gland right there with the frontoabdominal vein sitting on top, the right kidney. And then I've got pancreas here. And I'll make my way around the bend back here, which is the caudal duodenal flexure. And just looking at jejunum. Can I get a 22 gauge needle and a syringe, please? 3 ml syringe. So getting into the cecum there. If you can't find it, it's called a hidden cecum. And we've got our left adrenal gland there, which is quite enlarged. So big adrenal gland. Alrighty. So I see there's a question there, but I can't read it. I'm just retracting the duodenum here. Let's just pack everything back here. Can we get a saline-soaked sponge?
What difference would it make doing a cholecystectomy versus a cholecystectomy? The dog and the two dogs enter separately compared to a cat.
So cholecystectomy, it doesn't really matter whether it's a dog or a cat. I can't say I've done very many of them in cats. But the path of the common bile duct shouldn't really make any difference. So the first thing I'm going to do is I'm going to stick a needle into the duodenum and see if I have bile. If I have bile in the duodenum, which I do, so that's bile stain. It's pretty mucousy though.
This is called an invasive BP, so it's like constantly in the arterial blood pressure. More accurate than this one. So this would be so maybe like this. Like you want it to be.
So that is pretty nasty looking bile, although there is bile flow there.
Still want to flush it?
Yeah, I think I will cannulate that. So can I get some 4-OPDS, please? Let's see where that's coming in. Right about there. Okay, so just retracting that for me, please. Trying to get an approximate location where it's coming in. I'll put in a couple of stay sutures in the duodenum. Yep. So lift those out a little bit.
Suction. Can you just check that suction's on then?
We've lost the stay suture. Can I get some more hemostats, please? Some nuts and bones.
You've got those off then. That's great.
Can we get a cannula, please, like a 3.5 French? So we'll just see if we can see the common bile duct and the major duodenal papilla. There it is right there. don't know if you guys can see that. Putting that right down, major duodenal papilla, and that's going in really nicely. No problem at all. So I'll flush this very gently. I don't want to flush too much. So it's flushing easily. And I'm getting bile coming out through here. I'm just going to kind of pulse it out. Can I get another syringe, please? Like a 10 mil?
Keep walking the cat.
I do?
No, I do.
Oh, that's all right.
Has the room view?
The room view's not on.
Oh, it's not
No.
cool. Because I was going to say at one point my face was in it.
So I'm just trying to aspirate out as much bile as I can easily, just so that since there is some evidence of obstruction, at least we're getting some of the bile out. And it's not looking actually that bad. And I want to be really careful about how aggressively I flush, because I have created some pretty nasty cholangiohepatitis in the past by flushing too aggressively. Okay. So I'm happy with that. Now, I think I'll leave that open just in case we have a problem with the gallbladder. Can you lift up on that for me, please? Getting it out. I'm going to have you, Ewan.
Fine cautery tip on.
Hey?
Fine cautery.
Yep. Just retract on this down here, and I'm going to see if I can get around the neck of the gallbladder before I start trying to take it out of the bed. So go ahead and retract up there. Apologize if my head's in the way. If only one of us can see, it probably ought to be me. I'm struggling there, so I'm just going to go the normal way. So I'm putting a stay suture in the end of the gallbladder, and I'll place a cruciate stay suture because that's going to stay a little better. You definitely want your stay suture to stay. Alright, so let's lift that out like this. You can relax what you've got there. See.
Did you want to squeeze that out in?
Do we have our new cautery tip? Great, thank you. Can I get cautery turned down to 20, please?
Yeah. Okay. Yeah, thank you.
I'll just wait for that cautery to be turned down.
Got a small suction tip.
I know, all good. You can probably let go of that. So I'm just trying to get this. It's a very delicate little planar dissection. Can you get that out of the way for me, please? Thank you.
And then can you try 5 kilo forward started, and then reduce to 5.
Alright, we start at 0.2 milligrams per kg per minute, and it's at 47 grams.
I'll need a pump. I'm getting the deal with everything. You want this one in the separate line?
Pardon?
In the separate line?
Yeah, yeah.
And then take
move the cortisone across.
Yeah, okay.
So your plane, Charles, is actually within the wall of the
Gallbladder.
gallbladder.
You get that liver out of my way, please, for me. Just use a freer elevator. Yeah, that's fine. Just careful not to perforate. I'd get the freer instead.
You can stay on, maybe, in the hospital.
Anatomically there, Charles, are you kind of subserosal?
Yeah. I actually don't know what it is histologically. For find that if you go into that other layer, that layer that's just underneath the surface of the gallbladder, you're less likely to get hemorrhage and leakage of bile. Have this here. We've got a little rupture in the gallbladder, so we'll just have to keep suctioning that as we go. not catastrophic at all.
I'm doing it just saying that your head's gonna go.
Ewan's big head's in the way. Clearly going to be a surgeon.
I'm glad they're not paying for the view.
Actually, with the YouTube membership, they are.
That's what I understand.
Is that map actually 35? The third on point 5 was okay. The point 2. We actually think that one's
Yeah. Where is it gonna make for that?
start on point 5.
Yeah, watch that part when on.
There's no hemorrhage or anything in such.
No.
Yes. Yes, and one. I don't think that the outline that was in the book is so like this. She's on that second beautiful. Drop her hand a little bit. Add on 7, headache, get waking up to drop 55. So like,
Just trying to get that little bit right there. So we've got a really nice plane now. Another rupture down there. This gallbladder is just so friable.
You're fine.
I have to be really careful not to avulse the common bile duct, the cystic duct from the common bile duct. Can you keep suctioning in there, please? Let's get a little bit of flush. Yep.
Yeah, I'm struggling to listen closely to them, so. Yeah. Want me to drop it back more and more?
Yeah, right.
Yeah, go back.
Can you suction, please, for me down there? It's been really difficult. Let's pull that suction out, please.
I'm going to hold that cranially with a...
So suction for me, please.
Finer ones if you want them.
Oh, good. I think I'm just going to clamp this off here. So I've got a right angle across the neck of the gallbladder. And I'm going to come across on top with the hemostat. I have to be really careful not to retract on my hemostat at all, because if I avulse that off the common bile duct, I'm in big trouble. Okay, so I've transected the neck of the gallbladder. So that's pretty nasty. Get rid of that. Can I get some silk, please?
Can we get some silk, please?
Actually, this is pretty nasty. Let me get some 2O PDS. Okay, so hold on to that. All right, so let's just get a right angle, or get a debaki, and let's get just exposure of the neck. And I'm just trying to get my suture around the tip of my right angle without elevating it at all.
It's higher than 30. Try to get a shoe level. Just practice back to like 0.7. I think she'll release it around this now.
I want to as well, so she's painful, you reckon just have.
Okay, flash that, please.
Yeah, I think so too. Yeah. Maybe the levels, yes, is
Yeah, okay, off.
Remove.
Yeah. I'm going to re-grab that with my right angle and put another.
Inception.
Yeah. And this hemostat, hold on to that please, is actually a mixture. So it's not a right angle, and it's made exactly for, it's also called a mixture bile duct forcep. I think is what it's called. Can I see the tips toward, does it tilt toward me? Got it. You see how close I am to the common bile duct as well. Okay, and remove that please. Yeah, and out. Get some warm saline, please. Okay. So cut that. That was a pretty tricky one. I beg your pardon?
Are you going to place the dog on antibiotics for how long?
I'll leave that up to our critical care guys. I probably would put it on anafloxacin for a week and then see how it's going. We've got a modest amount of hemorrhage here, not much, not too bad.
Some more, Charles.
Can I get some 4O PDS, please? Thank you. Alright, so now we'll close our duodenotomy. Retract on that for me, please, just up there. Just going to trim this prominent mucosa. Just make it a little bit easier to close. then let's do a routine closure, and then I'll do a mental patch on that as well. So I'm going to start my suture line before my duodenotomy. And I'll leave this end long, and I shall use the suture as a stay suture, so Ewan is going to retract on that. Whenever you're suturing intestine, it's always, actually you can just cut that, we'll just use this. Whenever you're suturing intestine, you want to maintain tension on the continuous suture line to make sure that you don't put any loose suture bites, because that's how you get leakage. Just making sure that we're getting submucosa, because that's our holding layer. Putting my bites close together, and I'm avoiding grabbing the intestine with my thumb forceps if I can. And then I'm just going to use my thumb forceps to lay that suture exactly where I want it. Sorry, just a second. And I like to use loops to suture intestine for two reasons. One, I get more accurate placement of my suture bites, and two, everything looks bigger, and so I end up putting my suture bites a lot closer together than if I were doing it with my unmagnified old man eyes.
Do you have a technique, Charles, for maintaining tension, for instance, for people that don't have an assistant in surgery with them?
You can suture like this, where you use your own hand to maintain tension, like this.
Mm-hmm.
It's not going to be as accurate,
This part, you want like a nice waveform, like that?
but it certainly is a possibility.
Yeah, like say or something.
But if you can get somebody to scrub in with you, even if it's just for this part of the surgery, probably a good idea.
That's good. So it's giving me a waveform from that. So it's also giving me a heart.
Every time you take a bite, you want to make sure that the needle is exactly at a right angle to the needle drivers, because you want to give yourself every advantage in accurate placement of your bites.
Sorry, Will, can I just get in your here again?
Demi, I'm not sure what my next case is,
Mm-hmm.
but I'm probably close to the point that they can start knocking it down.
Did you bring your phone?
I'm ready.
The push should jump up, so I turn it down, but it just turn it back.
So I'm going past the end of my suture line. Yep. Alright, so let's have a look at this. You always go back and inspect to make sure that none of your sutures are too far apart. That looks really good.
Oh, I turned this down, don't want to shoot around.
Now where's some momentum? I can bring it across. There we go. I'll just suture that in a line across the top. Can I get some more 4.0 PDS, please? I've got it.
You got it?
All good.
So we can watch this. Sometimes it may be hard to tell, or we can watch this. Which is on here.
So anytime I enter the intestine, I'm pretty much always going to do an omental patch. It's been shown to significantly improve healing, reduce leakage.
That's okay. Points in it? Is it alright?
Yeah.
And there's no downside to doing an omental patch except for the time that it takes you to do it.
Yeah, this one? Frequency. Yeah. I'll explain those to you when we're not in the middle of happy.
All right, so we'll trade sides. Come in on the other side and get rid of this adrenal gland. Hey? Sure. Can I get some fresh gloves, please?
Either is probably fine.
And when I get this adrenal gland out and Ewan is closing, I'll go through and make sure I've answered all the questions on the live stream. So just grab onto that mesocolon, Ewan. Sweaty hands. And get the spleen out as well. Out of the way, not out of the dog. Alrighty. So there's our adrenal gland sitting here. And
Can I get this cat name rules now?
Yeah. Thank you.
I'm just going around the retroperitoneum using my little cautery hook. Make sure I don't hook the renal vein. Or the frontal-abdominal vein. Just get a little suction.
Quickly. Somebody again.
So I'm right up against the vena cava, deep in here. And there are mesenteric arteries close by. And then I'm going to ligature the frontal-abdominal vein first.
That's the one ventral to the normal adrenal there.
Yeah. Talking to me?
Is that renal there?
So that's renal vein right next to it. You can see why it's not uncommon to damage a renal vein when you're taking out an adrenal gland. And Will, my favorite question, why is the adrenal gland called the adrenal gland?
Because it's a gland.
What does adrenal mean?
I don't know.
Next to the kidney. Adrenal.
Oh, that is a good question.
And I will be honest, Will, I didn't realize that until fairly advanced. I was fairly advanced in my career. So I wouldn't feel bad. And I've just ligated that phrenic abdominal vein on the other side. Can you ligature underneath that, please? Can we get some, maybe some O-proline?
Should be in there now, proline. What's that?
Okay, so that's our big adrenal gland there, and that is quite large, peanut-shaped. So we'll send that off osteopath as well, and you can release everything you've got there. They've got no blood loss. There's the renal vein sitting right there. All right, so tuck everything back in the belly. Hope it all fits.
A bit unhappy. Got a big flush.
Yeah, big flush, and close it up. And I'll come over and check my proline and linealba because it's going to be on steroids long term. All right, so I'll come over and answer some questions here. All right, so I would probably just use fluoroquinolone, probably not metronidazole. I'm not too worried about anaerobes, really, in the gallbladder, but I will take the advice of the critical care specialist.
What do we actually do?
I don't use levoflox.
Cholecystectomy and
I haven't heard of it. It's not one that we use commonly. As far as doing a GDV, advice, basically you just have to decompress, derotate, assess the stomach, and then pexy. So decompress, derotate, assess the stomach to see if you have any necrosis, and then derotate. Just coming down here and looking at the rest of the questions. Liver complications that may occur. So you could have cholangiohepatitis after this surgery. There is a risk of bile backup if we hadn't flushed the common bile duct and established biliary flow. Also, when you get rid of the gallbladder, that's where usually you have stasis of the bile. And so once you get rid of the gallbladder, bile usually flows more freely. I assume that this is bile septic complications rather than uroseptic complications. So as long as you flush the bile out of the abdomen, you shouldn't be a problem. And that's pretty much it for me. So let's go back to
Can I see that? So I can update.
the surgery view. And so that's pretty much it for me. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications and join our YouTube membership because this will be switched over to the membership when I'm finished streaming. So again, thanks for watching, and I hope to see you again soon, maybe later on today.